I would like to introduce the speaker, and our topic today is very thought-provoking panel session, and involve the evolving landscape of periop medicine. So essentially, our first speaker is Ed Mariano. He is professor and social vice chair, Department of Anesthesia, Periop medicine and pain medicine at Stanford University. His talk is on social media in academia, 21st century tool to turbocharge. Unfortunately, suddenly he did have a conflict of interest, and he was not able to join us, but he was able to give us a recording of the talk. Our second speaker is Dr. Clyde Matava, who need no introduction. He is an associate professor, associate chief of Periop services for biomedics, and is the hospital for sick kids at University of Toronto. His talk is on informatics, significance to the future of medicine. So what we will do is we will have a Q&A session. Clyde, please take over. Thank you.
Thank you very much, Dr. Tang. It's wonderful seeing everyone virtually. I'm going to play Dr. Mariano's video, so we're going to try that right now through my screen share.
Thank you very much for inviting me to be part of this panel. I wish I could be there live, but unfortunately I had another obligation. So hopefully I'll be able to cover some of the important aspects of using social media in academics and provide you some of the practical tools that you can use to boost your own careers. And if you have any questions after this, please feel free to reach out to me. I'm very easy to find either on social media or by email. I don't have any disclosures. And I thought I would just start with some common ground. And really, for those of us who've been in medicine and academics, we know that CV is really a necessary evil. And for most of us, it's this lengthy list that just accumulates over the course of your career. But I think it has a lot of limitations. And first, I think a basic question is, does the CV that you turn in and prepare periodically, does it actually explain who and what you are and what you specialize in and what you're passionate about in terms of academics? But the other issue that I find with the CV is that frequently we don't update it as often as we probably should. Typically, we update it when we have to, when we're applying for a job or we're up for appointment or promotion, or if you're giving a talk and so someone wants your CV so they can know how to introduce you. But those types of formats really aren't particularly nimble. And so, I've really started to think about, well, how best to use online platforms, not just social media, but really this concept of having more of an online or digital presence as a physician scientist. And I think we all know that the use of the internet is a regular daily activity. So I think that it behooves us to really try to leverage the use of the internet and other online platforms to hopefully supplement the efforts that we put forth in our academic careers. Now, why do we even care? And I think this is really something that's important and maybe a little bit more specific to academics. But I know that when we do academic reviews for appointments and promotions at our institution, it's very important for us to be able to assess a particular individual or candidate's reputation. So why is this important? Well, having a reputation outside your institution on a regional, national, even international level is critical for the assessment of the scholar's academic activity, as well as the assessment for eligibility for promotion. And these are just some examples. These come directly from criteria that I've been sent when asked for a letter of reference for someone who's being evaluated for potential promotion. And starting from the bottom right, you see that as people progress from the assistant professor level to associate professor to full professor, going up to the top left, you see that there are specific comments that these criteria ask for: significant responsibilities, regional recognition, major accomplishments beyond the immediate site, and of course, national recognition. And I think this is really critical, especially as the makeup of our academic faculty has really evolved over time. So rather than having all academic physicians be particularly focused on research, we see many career tracks these days that really include the academic efforts spent in education and curricular development, as well as improvement science and other forms of scholarship that don't necessarily fall into the traditional definition of research. Now, this idea of having a digital presence or digital portfolio is not unique to academic medicine, and really comes from the larger world of education. And this idea of having your best work available for other educators as well as employers to view and appreciate, I think is really something we take out of the education world. This earlier forms of portfolios or academic portfolios really were on paper. There were paper binders that really showcased some of an educator's best work. The curriculum development, the assessment tools, some of the feedback, but you can imagine how more convenient a digital platform would be. So one exercise that I think is really useful, and I recommend that you do this right now, especially if you're already on a device watching me, is type in your own name, maybe your primary degree, into your favorite search engine, and just see what you get. Because I think this is really one way to assess what your online presence looks like. And while I think that traditionally, many of us who have been in medicine for 20, 25, 30 years have not necessarily thought about having an online presence as part of our careers, I think this is really becoming the norm. This is how we find anything. And I think that's really critical, especially when we think about how best to develop our own online presence when trying to accelerate and hopefully promote our own reputation. So what do you use? And I think that this is where there are a lot of choices. And in terms of social media in particular, you can see how some of these were ranked a couple of years ago. These statistics have not been updated by the Pew Institute as of yet, but you can see that YouTube, at least, has continued to stay as a very strong favorite, especially when it comes to just-in-time videos and training. You can also see that Facebook, which has been around for a long time, continues to be very popular, particularly in certain demographic groups. And then you see a number of other platforms. And as you can tell from my slides, I tend to prefer the use of Instagram as well as X, which is the platform formerly known as Twitter. The bottom line is just use what you're most comfortable using, because social media, as are all forms of communication, really are geared towards the user. So part of the advantage of having so many different platforms to choose from is that you don't have to use them all. You can just use the ones that you think are probably the most amenable to the work that you're doing. So for example, if you're an educator and you like to teach on topics, whether they're long discussions or small, just-in-time types of teaching videos, I think in particular in my area of regional anesthesia, I think these are very amenable to video-based content. YouTube makes sense as a very popular outlet. Not only can you share all of these, all of your work very freely, but at the same time, you can also gather metrics as far as how often that your content is accessed, how many subscribers you have, how many views a video's had. I think that those are very helpful, especially when you're trying to gauge metrics for your academic assessment. LinkedIn is a common platform that's used mostly by business people, but at least that's the way we think about it as physicians. But I would say that of the platforms, LinkedIn really has many of the features that I think constitute a very strong online CV. You can see in the red box how you can actually highlight specific areas that you want people to know about, from your CV, and keep this updated in a much more regular way, as opposed to just having multiple versions of Word documents on your computer. So you can have your publications, you can have if you own any patents, if you teach courses, you can also have links to other content. You can see that I have some of my recorded lectures on YouTube that are linked through my LinkedIn profile, as well as honors, awards, languages you speak, and activities in other organizations. So if you haven't started a LinkedIn profile, that's probably one that I would recommend, because this does become a public-facing CV for you and makes it easier for people to see what you really specialize in. And then if you have other platforms, and this is just one example, I'm not saying that everyone has to have this, but I have my own website. It's something that my brother actually started this for me before I started my current job. But if you have access to other platforms, then link out. So I tend to have my recorded talks on YouTube, and then I can have one-stop shop for having links to those recorded presentations through my website. In addition, you can use LinkedIn for the same thing. And I mentioned how you can, if you already have your content recorded somewhere else, then like, for example, on YouTube, then of course, you can go ahead and you can link that as featured content on your LinkedIn profile. So definitely think about this. I mean, a lot of these platforms really tend to work well together, and they cover various facets of your academic career. ResearchGate is a specialized online platform that's really geared, obviously, towards researchers. I bring it up only because, while it's not one of the top platforms that you saw me list on the Pew Institute data, it is very specific to the researcher. And where I think that this is very helpful, especially for those of you who are thinking about how best to reflect the impact of your work, ResearchGate provides a lot of statistics. You don't have to pay to open an account, and you can see how, if for any investigator, anyone who publishes work, you can see how often your work is cited. So that's a very traditional metric. You can also use that. You can find your H index, as well as a separate unique index that ResearchGate creates, which is actually the RG score. You can also see how oftentimes people on the platform, other researchers, happen to share your work, recommend it, as well as read it, especially for those who are searching for content in their area. And if you happen to be a researcher and you don't have full access, and now, of course, if you're at an academic institution, you probably have library access, but assume that you're not. And so many of our colleagues around the world are often blocked by paywalls. Well, ResearchGate allows investigators to communicate with each other. And so there is that potential to make connections and then share work that way. The other thing that's really important, especially when you get to that highest level of promotion where you're trying to become a full professor, is really showing the impact of your work outside not just your institution, but maybe even your home country. So one thing that ResearchGate collects are the locations of users as they access your published content. So you can see within a week, you can see like how many different people on the platform in different countries accessed your work. And this may be a way that you can demonstrate the reach of your particular published work, especially when you're trying to convince an appointments and promotions committee. And this is just an example of scores. And so you can see how you can find your H index, which is more a very traditional metric that libraries often use, as well as a more specific RG score, which really is developed to assess the impact of the users of ResearchGate. So how do you currently think about capturing your activities? I think it's a good pause. Is what you're using right now, is your CV or other online platforms, do they represent your contributions in a way that you think they should be represented? And are you missing opportunities? I think this is really something that we all need to think about, especially as we really try to connect what we do in medicine, science, and academics with the rest of the world that is using, for the most part, using online platforms for everything. And so I've talked about social media a fair amount. I've written about social media. For those of you in regional anesthesia, you may be familiar that I think that regional anesthesia, I think, is a great area of subspecialty that has benefited from social media. And I won't talk so much about that topic right now, just because I've discussed it before. But feel free, if you want to scan the QR code, you can go to an article that I wrote not too long ago for the European Society of Regional Anesthesia and Pain Therapy. I also think that we have many ways that our colleagues, I think, have really developed great online content. So I just wanted to give you some examples. These really fall into the area of social media because social media at its very basic definition is just creating and sharing content. So this comes from some of our colleagues at Duke Regional Anesthesia. They have a fantastic YouTube channel that has just-in-time videos as well as longer, much more in-depth lectures. These are great resources and also help us not reinvent the wheel. So when I want to recommend resources for our trainees who are on their regional anesthesia rotation, I tell them, I know you're going to look it up online anyway, so you may as well go to a good source. And there are other platforms as well. And I think that if you're someone who is a very passionate educator and you're able to create short videos that people can use for education, like Dr. Melody Herman on TikTok, or a podcast. So this is actually a podcast from Jeff Gadsden and Matava called Block It Like It's Hot, entertaining and also educational. And then, of course, you can go to other social media platforms. And I mentioned I still use X, formerly Twitter, a fair amount. And I think that that's a good way to generate dialogue. Those are, I think, many of the ways that we as academics in science as well as in medicine, I think that continue to learn. And the reason why I bring this up and why social media, I think, is such an integral part of my career now is because I think it really is part of how we develop good questions. And I put this down as just a food for thought, but where do good research ideas come from? And I think that on the one hand, I think we still have make observations in clinical practice. We have good conversations sometimes in the break room or in the hallways. We also read articles, and oftentimes research articles will tell you what's missing in the literature, and they suggest subjects for future studies. But social media, I think, is another really important way that we can observe, and observation really is critical, I think, to the scientific method, to the point where I think that we really have this opportunity to employ it in a much more regular basis. This is just an example. So I give just one case study. That you see a Twitter conversation that we were having a couple of years ago, just about like the minimum number of blocks that trainees need to learn before they finish their residency. And I think that what's fascinating about this is that you see, I made a comment about our ACGME requirements for residents in the US, requiring 40 experiences with managing patients with peripheral nerve blocks. But these days, we have so many different blocks now that a resident can perform 40 blocks one time each and not really know how to do anything. And so a friend of mine, Lloyd Turbett, who's based in Belfast, made the comment that, well, we should have 100% of anesthesiologists competent in 5 blocks instead of 1% of anesthesiologists competent in 100 niche blocks. And this conversation that we had on social media became an editorial in the Journal of Anesthesia. And then that actually led to a study that we did during the COVID pandemic, a 3-round Delphi study with experts participating in this consensus project from around the world to determine what are those things that we should be teaching our trainees. And so this is one case study, not the only one that I have had so far, but where really these discussions on social media became academic productivity. And so I want you to think about social media as it pertains to the scientific method. And this is a paper that we wrote for anesthesia, just integrating this concept of social media within the scientific method. We called it the social media scientific method. I think that we can monitor social media conversations. We can have online journal clubs. This allows you to have conversations, to observe, ask questions, generate hypotheses. You can network with potential collaborators through social media, as I demonstrated in the previous example. And that can actually lead to design and conduct experiments. You can collaborate virtually these days. We've gotten all very good at virtual platforms. And then once you finish your project and you want to publish it, you can publicize that work using social media. And I think that really allows you to disseminate your work. This is just one interesting study published now over a decade ago, just showing how early social media buzz or attention leads to downstream citations. In this particular article, they evaluated papers that were published and had a great amount of social media attention. And then they found that years down the road, because sometimes the timeline for citation takes months to years, that those highly tweeted articles were 11 times more likely to be cited. And citations, remember, are a very traditional metric, and every academic institution, every appointment and promotions committee looks at this. So if you can put it all together, then going back to the same paper that I discussed already, you can see the altmetric score for that editorial. It was fairly large, actually one of the larger altmetric scores that I've had as a published author. And that actually had a direct impact on real citations, and currently cited by 68 papers. In addition, we've also seen that this concept of having basic blocks for all anesthesiologists in training has been adopted by Regional Anesthesia United Kingdom. And so they've actually started to create curricula around teaching people how to do blocks like this, these basic blocks for everyone. And so you can have a lot of impact. And I'm fully convinced that not only did this idea come from social media, but I think the dissemination on social media has had a real influence on the ability for this idea to change educational practice. So if you want to learn a little bit more, this is a link that goes back to my website. I have some resource articles for those of you who may be new to social media. I learned social media and not growing up because we didn't have the internet back then. We didn't carry phones around. So I had to learn it as a professional. And I think that if I can learn it, anyone can. But thank you again for allowing me to be part of your panel. And please feel free to reach out to me if you have any questions. Thank you very much.
And thank you for the invitation. And I have no conflicts for this talk. And goal is to outline just the role of clinical informaticians. Tell a story of how the data that are usually used in traditional metrics do not necessarily tell the full story. And so to get started, we'll define essentially what a clinical informatician is. And these are definitions that have been used. One is by the American Medical Informatics Association. One is by HIMSS, which is a very important organization that is pretty much the academic center or scientific center for a lot of research and work that goes into the HR systems that we use. And the last is just AGME, who actually recognize this now as a subspecialty of medicine, that anyone with any medical specialty can do further specialization in clinical informatics. That's something we don't have really available in Canada as yet. One can do informatics, clinical informatics through other universities, but often enough, it's not part of the main Faculty of Medicine endeavors or offerings. And what it really does is that clinical informatics brings together information systems, of which the EHR that we use is just one of them. There's several systems. An expert in this area understands what workflows are and processes that impact people, human factors, things that may influence behaviors if they're shown on a screen. Also, there's a very strong aspect of leadership and management, because a lot of this does mean management of people and change and keeping that sustained. So really, a clinical informatician can be involved using just this graph in helping implement each and every one of these. And often enough, hospitals that have clinical informaticians, often these are teams of physicians who work together, or in some instances, also part of their society special interest groups related to informatics. They often have leaders from different specialties who work together to achieve some of these. Anesthesia is just one of these specialties. And so within the US, clinical informatics is now board certified, I mentioned. And in fact, this is an older paper from Frankton Dexter, who was doing a lot of this work before this was actually defined, along with Rich Epstein. And they wrote this paper where they surveyed the board-certified anesthesiologists and clinical informaticians in the US. And really what they were looking for was to what extent they felt supported within the hospitals. This particular paper is out of scope for today, but it's something that is worthwhile reading. And in other editorials and letters, there's actually a push for, we probably do need people within anesthesia who are invested by the hospitals, institutions to become clinical informaticians, as the evidence does suggest that when such people are in place, those hospitals end up having some of the higher return investment on the EHRs. So when physician leaders are included in informatics, clinical informatics, then it seems to be a huge benefit for many. And so to date, there have been fellowships offered, some of them within the whole New York area. Stanford as well has an informatics fellowship that is formal, and a lot have been written around this area on how we can achieve more anesthesia informatics as an area of interest or focus within anesthesia to help bring the same rate of returns as others have yielded. And one very obvious reason is that as there's a move towards electronic record-keeping system, definitely across Canada, we are behind the US for the most part, and but still ahead of many countries across the globe, is that this transition has demonstrated that a lot of the papers that have been of high impact that use a patient-derived data are usually using some kind of AIM system, anesthesia information management system, or hospital-based system. And the use of paper data for publication is probably pretty much disappearing in anesthesia. Across Canada, we published in the Canadian Journal of Anesthesia just a work looking at when would have electronic record-keeping systems for anesthesiologists across the country. It does look as though 2024 is promising for most of the country, but the few that will actually go onto EHRs for anesthesiologists, perhaps in the tail end of 2026 or thereafter. So how does this bode in then with the whole promotion question? So this is straight from the University of Toronto website, Faculty of Medicine, determinative Faculty of Medicine criteria for promotion, which for senior promotion is looking really at associate professor, where candidates must demonstrate a national reputation, and definitely to full professor, as Ed alluded to before, is an international reputation. And so really the story that one has to tell and hopefully have the data to demonstrate this is definitely sustained local impact, a national impact for associate professor, and international impact. Traditionally, within the research area, these are the metrics that have been used for the most part: publications, citations, H indices, and other indices that have come up together, presentation at conference, visits and professorships, funding, which I do not include here, but also reputation, international reputation from many people. So these metrics are easy to generate for those involved in research or who publish some of their work, but they're virtually impossible to generate if you don't have publications. And so what I propose, and certainly this has been something that we are looking to publish with some of my colleagues in this area, is what could be academic metrics for clinical informatics. So one is very quickly, what are the number of patients impacted by the work done by that clinical informatician? The number of healthcare providers who do use that work routinely. What are the instances of the workflow being implemented? Intellectual property, policies that have been generated as a result of this, instances of actual decisions made for the safety of patients, and where possible, publications, citations, H indices as well. But really, these are probably additional and extra over and above the impact that the clinical informatician's metrics will demonstrate. And so to try and perhaps demonstrate this in different ways, I have a few cases that I'd like to highlight that demonstrate definitely the first 4 or 5 of these, and in some instances, go ahead and demonstrate where publication is available. And right away, you'll be able to see that it might be one publication with a reasonable number of citations, but the question is always, has this translated to actual patient care? And that's something that traditional research academic metrics cannot demonstrate unless there is a particular manuscript that demonstrates how that particular tool has been used for actual patient care or in additional research downstream. So the first case is actually from my institution by my colleague and friend, Dr. Connor McDonald. So in essence, Strabismus surgery, as we know, has one of the higher incidence of postoperative nausea and vomiting. And in fact, up to 50% of these patients can develop this. And so Dr. Conor McDonald, as the lead for patient and quality safety, put together, along with the team that worked with him, a paper-based bundle that suggested the use of 4 types of medications to reduce the postoperative nausea and vomiting in these patients, and the use of a long-acting opioid. And these included dexamethasone, ondansetron, ketorolac, IV Tylenol, IV acetaminophen, and also the use of a long-acting to help reduce pain. So initial work published how this really a project had run over 4 years, and the first data to show that it had been a long-lasting effect on this. And then subsequently published, after we went live on Epic, how we translated that tool into electronic format as part of clinical decision support. And so what you see as a result of the second publication is that when this tool went live, this is just using SPC charts to demonstrate the impact, is the compliance with the bundle did increase somewhat after the tool went live. Department rounds, discussion around this, you can see that there was a slight increase. But this increase actually became sustained when we went live with our EHR, because we then translated this into a mandatory field that showed up when one was looking after strabismus cases. But not only that, through this work, we're able to demonstrate also a sustained reduction in PNV and ultimately pain as well for these patients. And this has been sustained. So translating this, which work that led to 1 publication with n number of citations, and definitely contributing to Dr. McDonald's H index by a factor of n. But how does this translate in actual patient care? So since that went live, this tool has fired on our instance in 842 cases. This data is literally from 2 hours ago, updated this number of cases that they had strabismus surgery at SickKids. It fired on all cases, and there was 87 sustained compliance with the use of those 5 medications to date. And to our knowledge, 2 hospitals have adopted the strabismus bundle internationally. There's no publication for this, but this is something that has been communicated that at least 2 hospitals that we know of use this tool internationally. So in this instance, the publications are one thing, but being able to demonstrate the impact using more this metrics can actually help perhaps tell the story, showing the impact, not only local, national, and even international. The second one I want to highlight is a story that started in about probably 2015, coming from Dr. Jessica Zimmerman, who's based at Connecticut Children's Medical Center. The situation in this instance was that this is something that is true to everyone, no pediatric or adults practice, was that often enough, medications that have been administered to patients as they move across the care continuum is not always easy to tell where they are. And in the more complex cases, the AMAR is very long. And it's not always to tell when what was due was given. In a patient who might have 15 medications that are all due at different times, in different formulation, different strengths. There's obviously a long list of medications, quite a huge demand of one's cognitive load. And there's definitely alert fatigue that's present from too many alerts versus precise alerts that fire up. So what Dr. Zimmerman and the colleagues developed locally at their hospital was a tool, also within our same, we happen to use the same EHR, that actually identified all medications of interest to anesthesiologists. And anytime an anesthesiologist opened the patient chart and any one of those medications had been used, there was a flag that showed with a very visible color and very visible terminology. And this really reduced the cognitive load, because it meant that as soon as I opened that record for the patient at any time, even including a few months before induction, I see all the medications that are of interest to me, whether these are whether this is heparin or any medication that, thrombolytics that have been given that might mean I don't necessarily have to give a regional technique or avoid a neuroaxial technique, or even Tylenol, which is one of the most commonly double-dose medications within the pediatric practice. And so this tool shows this automatically. So what's the size of impact? So remember, number of patients, number of healthcare providers, instances where it's used, and perhaps policies, and maybe, hopefully, publications if possible. So this work, I'll start internationally. This work has been adopted in that time by over 300 organizations. Just this year alone, this tool has been used 175 million times, just this year alone, which is phenomenal. And at SickKids, in our instance, we've used this tool about 172,000 times. And we know from our local data that this tool has gone on to actually pretty much bring to zero our instance of patients receiving additional dose of ondansetron when they're on a long-acting like dolasyntron or one of the longer-acting 5-HT3 blockers. And so while there's no current publication, this tool, we know from routine practice, has made significant impact. And I think over the years it's been live, this tool has been used almost 1 billion times across the globe. And at SickKids, we are over about half a billion times this tool has helped in our patient care. And so yet again, being able to demonstrate the story using metrics that can depict local to international is very helpful. The last case I'll demonstrate is one that we developed at SickKids. When we went live with our system, there was no way actually of documenting induction behavior in children, something that we all would agree is very important and can help inform their downstream care by knowing what to avoid and what to give them. So in this instance, we actually took a systematic design with a group of colleagues from about 14 pediatric hospitals, where we did a systematic review of the literature on the best tools available. We looked for one that had been validated for electronic use. And through a series of permissions and licensing for the tool, we actually then developed this tool embedded within Epic. And so this tool is now used at this institution. So since we went live with the tool at SickKids, it's been used in over 100,000 anesthetics with a completion rate of 79%. In Canada, it's now used across 5 hospitals. And it's used across, this data is about a year old when we published our work. About 133 organizations, but I understand this number is doubled since. And at that time, it was just 3 million anesthetics at these pediatric hospitals, but we expect this number to be in the double digits of million of cases. And in this instance, we were able to actually publish this work and demonstrate at that time the use across different geographies and cultures for this tool. And so in essence, some of the metrics we need to consider then if one is using clinical informatics to help inform academic promotion for oneself or sits on a decanal committee to review this is really something that I believe should be probably the ethos is what problem is being solved? Is it something that is measurable before? Because this helps show the difference when the intervention has been put in place. Sometimes there's no existing data. It's just such a novel tool that's been designed. But it's possible to track the data and the use afterwards. Is this the right solution that's used at the right time? And then what is the effect of the solution? And what is the impact of that solution on patients? The last one is not always easy to demonstrate, and sometimes it is, and sometimes that is what might lead to the publication. But a lot of the informatics journals are willing to publish a lot of work that shows a sustained use of a tool to help improve the workflows, or the documentation, or other techniques within anesthesia, or any medical specialty. This here is a website of a resource of different anesthesia-related informatics papers. Franklin Dexter has maintained this for the longest time, and they easily, I think, hundreds, if not thousands, articles for one to peruse that might be able to give one ideas of how to, if the particular use case lends itself to publication, how might be able to structure publication for this. So one of the things I think definitely in Canada and our national society is to begin to work collaboratively in designing systems that can be adopted across the country. This is something that we have done at SickKids, and they've done that within the pediatric hospitals. And as the adult hospitals come on board with the EHRs, I think there's opportunity for us to work alongside them to continue the work that we've done to date in different ways across the system. The story is not always obvious, as I mentioned, just looking at traditional metrics. But if one is able to document very carefully as you do the work, the different stages you make decisions, the impact it has on your documentation quality, then it's very possible to have a story that will show the impact of the work of clinical informatists, not informaticians, not only within anesthesia, but other specialties as well. I just want to acknowledge my department who support a lot of the work that I do. And I definitely look forward to the questions. And I will try my best to take Dr. Ed Mariano's questions as well, as I've had the privilege working with him within the social media space. Francis, over to you, and thank you.
Thank you very much, Clyde. This has been really excellent, and thank you so much for everyone in attending. What we will do is Q&A, and Clyde will answer all the questions. You can either raise your hand or you can type your message in the chat sections. So go ahead and ask any questions that you would like to ask. Anybody would raise their hand? So maybe, Clyde, I want to ask you some of the questions. The old-fashioned is the website or the blog. Is anybody using that now, or this is out of fashion?
Yeah, that's a good question. I honestly can't remember the last time I read a blog, per se. But, you know, with all respect to all the journalists, sometimes the news articles themselves read like blog articles, you know? But it's, so I think the whole thing of blog, it's gone from the old way more into, I think it's now part of just the way, you know, news is shared. Sometimes, as I say, some of the articles we read on news are more like blog style. And likewise, a lot of the journals now have sites that have kind of, let's say, soft publications that are more blog style, because they're more conversational. They can allow input from experts, including yourself, in a way that is, you know, not so much about the best evidence available, but just what expert opinion is. So, so I would say, I think the blogs have just evolved over time, and are probably now part of just the main way that news is shared. And they're no longer necessarily called blogs, but people do read content from them. I think what has taken off is definitely, I think, X, now Twitter, or Twitter, now X, which I, for whatever it's due, I think whether it's going to persevere into the future, that remains to be seen. But also other microblogging tools, as we know, have now become on board, including LinkedIn, that Ed alluded to. That's very professional, but also has kind of blog-like features, microblogging. I think Facebook have their own tool now, Meta, for microblogging, and as well as Snapchat, which some use. And there are also quite a few anesthesiologists who are on even more the video-based tools that they create small videos and post learnings as well. So there's a lot of, I think, plethora of tools out there. I think the issue is not should we use them, but I think just they will evolve with time. And a lot of the tools do allow a user to generate metrics of the impacts of the content they share, as Ed alluded to.
Right. Thank you. Beth has a question.
Right. So first of all, thank you. This has been fantastic, Clyde and Francis, for sharing the session. I'm getting text messages saying, this is amazing. This is so good. And it's really helpful. Francis, you initiated this rounds in part because of your role as chair of the Senior Promotions Committee. And I know that the group was trying to help our colleagues understand and ourselves understand how we can start to capture these reports and so forth on social media. Do you envision a toolbox of any type or some sort of questionnaire checklist so that we can start to constrain our thinking and, in a sense, harmonize the way we're presenting the information to our promotions committees? Because it could be all over the map and a little hard to get our heads around.
Yeah, Clyde, you have any comments?
Yeah, thank you, Bev. I just, in response to your question, I just posted a link that I hope people will access in the chat. So there's been some work around that, how social media can be used for promotion. And in fact, if you look through the reference, the citation papers for this article I shared, some institutions have actually come around with a way to organize the metrics from social media. The authors in this paper did make a suggestion, and particularly Harvard has actually some standardized way of looking at the metrics, the impact of this. That's also an article that I can share through Francis after this call is done. I think it's important. I think you'll see they have a great table on who's using, how often it's used across the country, way of being able to summarize what the impact means, and also the interaction. How many people actually have interactions? Some people might post, but there's no interactions. But I think one of the metrics they do is the conversation around this, is that if you generate a lot more conversation or more likes or retweets, it means that your content that you're creating on social media is probably having an impact. And yet again, it is an impact on people. As I say, to draw a line from social media posts to impact on patient care is a lot more difficult and challenging. So really the impact is still limited to perhaps changing the and influencing just the decisions and thoughts that colleagues have around certain topics through dissemination of your knowledge through social media.
Okay, Clyde, there's a question from Himad, and he's asking, what are the risks of social media?
The risk, that's a very good question. I think we've had quite a lot of interaction with the Canadian Medical Practice Association, looking at the CMPA, and they, on their website, I recommend that they have some really good advice on close cases where physicians might have undergone through some litigation and their CMPA settled. And so they provide very good advice on what to avoid posting online. And in addition, different societies have developed different guidelines. And most recent, as Bev, our chair, highlighted, is that at the University of Toronto have an ongoing working group that's looking to also provide guidelines on what to be used, or how social media can be used by clinicians, much like ourselves. So I would say probably the best line is to look at your national societies, see what they have, and work down there from your licensing bodies, and then your university departments, your hospitals, and maybe even your department. Some departments have guidelines for their own groups on how to interact with social media. So I think across those is probably the right thing for you. And I recommend that you contextualize the use of social media to your own jurisdiction, because that is not the same across the globe, and the risks are different across the globe.
And also Beth did post the link to the guideline of social media, which is provided by the Task Force of University of Toronto. So it is in this chat earlier. So actually Hillary is asking, good papers get cited, and good papers also get discussed and shared on X. Treating and the increase in citation could simply be epiphenomenal. Can you comment on this?
Hillary, you had to give me one of the more nuanced ones, right? So I've tried to look at this as well, at papers, and yes, there is an early indication towards citation. I think different people have done different studies, univariate analysis, multivariate, like trying to see the signal for tweeting alone. It seems as though, yes, tweeting early is associated, not necessarily, I think it's just an association, to be honest. I think the confounder that is very strong is high impact journals. High impact journals have a very profound impact on the future citations without fail. So I think we're still to do a really good study that controls for that, in a very good way. And I think now that tweeting has been available for over a decade, I think we have enough to do that. And also is that I think what we've looked at is trying to look at the citations within a year, because we find at the 3-year point, some citations can just dwindle, and then some papers actually get cited, 3 to 4 years afterwards when that topic becomes of interest to the wider scientific community, but initially it was not really relevant to scientific community. So there are quite a few things to consider in there, but I think the time frame and window in which these metrics are being measured is pretty key, because we do know there's a fall down in some citations, where some citations pick up for some papers, 2 years after the fact or 3 years after the fact. I don't know if Hilary had any further comments on that, but I'd love to hear your thoughts on this as a former editor of our leading journal in Canada.
Hilary, can you comment? Would you be able to comment on this?
Yeah, I think a lot about tweeting and citation, and as journal editors think about it all the time. How can you get the message out there more, and will it lead to more citations of your journal? But I don't think that we really have good evidence for that. I often wonder whether it is just two things that are true but unrelated. It'd be tough to do a study though. You'd have to sort of do a study where you have authors agree that they are never going to tweet about their own work, versus authors that will tweet about their own work, and then you could actually see if there's an impact. But you can't really control for that phenomenon that even if the authors refrain from tweeting, others unrelated to the study may see a good paper and start sharing it. So it'd be a pretty tough one to follow. But there is a general thinking I think amongst journals that tweeting does help their citations, but I just don't know if it's actually true.
It's a good, it's a very good thing. So we need a study. Well, actually, there was a randomized control trial done on this. And it did show that actually the group that was tweeted, I think it was a journal that over a year randomized which articles in that issue would be tweeted and not tweeted. And they actually showed that those that were tweeted had a shorter time to citation and more citations at the 2-year mark than those that were not tweeted. So I think there is some evidence, but I think it's more complicated. And I don't necessarily believe that some of the high power researchers are all on Twitter. They probably don't even see it, but they probably see those articles with other more research social media, like ResearchGate, Mendeley, that have social media capabilities. So while I think Twitter is a very well-known one, that's a very out-facing, I know that some of the researchers look more to ResearchGate or Mendeley that have some social media tools within them for notifications. And that is actually a type of social media as well, but just not as well studied as Twitter.
Yeah, thanks.
And also some journals, I find that they are doing podcasts. Like I have several podcasts, which is done by the journal. They actually, when they publish the paper, they would do podcasts. And the other two that is very good is if the journal actually make it open access so that everybody can look at it, so the citation impact will be increased. If that is the case, or the university has the money to support the open process of publication. So Margarita here is asking, how does Panorama integrate with the growing availability of AI tools and AI-generated content?
Thank you, Dr. Otara. That is a very pertinent question. So I think the bottom line right now is there is no really strongly validated tool within the anesthesia space for AI-generated content. It's a very broad area, but in this instance, I'm talking specifically to the patient records that we use day to day. There is work, however, looking at the use of generative AI. That's looking to summarize medical histories for patients, some of the patients, the more complex history, and actually look at all their medical history, look at the text and summarize that for a clinician, much like yourself or myself. So we don't have to dig through the entire medical record. So our HR is working on that right now. We've actually reviewed some of the prototype for anesthesia for that work, and it's promising. That also actually can generate an ASA score. That's something that actually has been validated already, where ChatGPT can actually assign AS scores more consistent than physicians, and it will be actually help reduce the workflow for physicians in assigning ASA scores for patient record. The other things that are under the work, summarizing notes, even making plans for patients based on learning how you do it. So there's quite a bit of work. It's very expansive work. And in that is also work around, machine vision, the use of AI to help perform procedures such as regional anesthesia, airway management. And so these are some of the things that within my institution, we are beginning to understand. And there are different trials on the go within SECIDS looking at these tools. One colleague is looking, for example, the use of AI for cardiac echoes, interpreting cardiac echoes by anesthesiologists just during routine surgery using AI. So there's a lot of work in this area. Some of the work try to predict, say, for example, hypertension, and quite a few papers published around that. But the challenge has been how to integrate that into clinical care. And also it's not always easy to use those models for all patients under one's care. It's a huge area. I think there are hundreds of people working on this, and I'll be excited to see what actually matures into routine use over the next few years that we can all benefit from all the wonderful brains working on this across the globe.
Thank you, Clyde. I'm going to respect everybody's time. We're going to end the seminar. And if anybody has questions, I'm sure that both Ed and Clyde and myself would be happy to answer all your questions. And I do remind everybody to actually update their CV so that they can be promoted to assistant professor, associate professor, and also professor, because it is very important that you get recognized for your work. Thanks very much and good evening. Bye-bye.